Hi, everyone. Thank you for attending today's infection prevention module lecture 302. We are going to talk about C. diff, one of our favorite infections. Today's lecture, we are going to briefly talk about the NHSN, or the National Healthcare Safety Network, C. diff epidemiology definition, and then discuss reduction efforts that we can use in healthcare settings, specifically for our patient and our healthcare workers, to try to reduce our rates. My name is Dr. Kayla Rush. I am an infection prevention practitioner, and I'm also an infection prevention epidemiologist if you're new here. And thank you all for coming. Okay. If you're new and this is the first TEPI lecture that you have attended, I just want to give you a brief about us. We are the Texas Epidemic Public Health Institution, or TEPI. We are housed in Houston, Texas, at UT Health School of Public Health in Houston. We are a specific organization that really, our goals are to keep the Texas safe and build up a strong economy by increasing our capacity for resilience, to help prevent and respond to future infectious outbreak. And if you want to know more about TEPI, there are some QR codes and links at the end of the lecture. Feel free to check them out. Like our previous lectures, today's lecture is recorded. You will get a link to the recording about a week or so after the lecture, and along with the slide deck. So today's lecture is recorded. You will receive an email with a link to the recording in about a week or so, along with today's slides as well. I ask that we wait for all questions to be answered at the end. We're going to go through our learning objectives. Specifically, we're going to describe our C. diff infections, discuss reduction and prevention efforts, both on staff side that we can do to make sure our patients are safe, and then also discuss patient engagement initiatives that really help our patients become part of our care team, and ways that we can help them understand C. diff infections and what they can do to keep themselves safe. So let's talk about C. diff. C. diff definitions are set by the National Healthcare Safety Network. If you're new here, we've talked about different healthcare acquired infections, or HAIs. And the National Healthcare Safety Network is a part of the CDC that comes up with the tracking definitions of healthcare acquired infections, which are also the system that we report in the healthcare systems into to log our HAIs that are happening across the country. And today's HAI that we're going to specifically talk about is C. diff, which is an anaerobic, meaning it doesn't like oxygen. It's a spore-forming and motile pathogen. This pathogen gets in our facilities, and it's really hard to kill since it is spore-forming. It can go into a vegetative spore state and really stay dormant in the environment for weeks to potentially months. So this is a really hard pathogen to get rid of. That's why we kind of see C. diff rates. It has two toxins that it produces, are enterotoxin A or a cytotoxin B, which can cause a lot of damage and illness to individuals, specifically in their large colon. Symptoms can range from diarrhea to life-threatening damages of the colon, and potentially can lead to death and causes mortality in some severe cases. So just a little bit about C. diff infections and why this is so important is that the CDC estimates that there is almost 500,000 C. diff infections in the United States every year. That's a lot of infections. And about 1 in 6 patients get C. diff, and they have a recurrence within 2 to 8 weeks. Most symptoms, the tried and true symptom that we see with these C. diff infections are the very watery diarrhea. Patients will have a fever. They will also have a high white count. Their stomach will be tender, very painful. There'll be a lot of abdominal cramping, pain, loss of appetite, nausea, and then sometimes blood or pus in the stool. Some complications that can increase the severity of the disease will lead to dehydration. It's an inflammation of the colon, knowing colitis. That is when the colon gets really inflamed and irritated due from the pathogen, and it can cause severe intestinal conditions such as a toxic megacolon, which is when the colon gets really huge due to all the inflammation that's occurring in the colon. Some specific risk factors are our elderly patients, which NHSN defines as 65 and older. Previous antibiotic use would be a huge risk factors for developing C. diff for these patients is broad use of antibiotics. That's why having a good antibiotic stewardship program is so important, and that we are giving antibiotics appropriately for the correct pathogen, duration, as well, and that we're not just starting and stopping antibiotics, or we are giving antibiotics for any viral or fungal treatments as well. That's inappropriate use of antibiotics. You should be giving antivirals to those individuals or antifungals for those individuals. Other risk factors include previous medical history or surgical procedures. If anyone has IBS, a weakened immune system, chronic kidney disease, other issues going on with their GI tract, or if they've had any type of stomach surgery or procedure that can disrupt our natural microflora or our gut microbiome, which is the good bacteria that's in our GI tract that helps protect us. When we go into surgery and give different antibiotics that can disrupt the good bacteria and make them go away, that leads to a opportunistic pathogen such as a C. diff coming in and then colonizing and being able to grow because we don't have that good bacteria to fend off that area. And just like with any other healthcare acquired infections or HAIs in the US, about 1 in every 31 patients in hospital settings, that could be our long-term care hospitals or acute care hospitals, and then 1 in every 43 individuals that live in a nursing home will develop at least one infection associated with their healthcare environment. So those are some pretty big numbers. This is a current thing that goes on. So we really need to make sure that we have good infection prevention and control measures, policies, procedure, and education to our staff to really help prevent our patients or our residents from developing these types of infections. So in 2023, the NHSN and CDC kind of gave out their overall numbers of HAIs every year. There is a report saying how we are doing with our specific HAIs. The 2024 data isn't ready yet, but in 2023, we did see a decline in HAIs compared to 2022, so that's great. And then specifically in C. diff, we saw a 13% reduction, which is great. And just like with any healthcare acquired infections, we have our National Healthcare Safety Network or NHSN, our manual that tells us how do we define these infections, how we should work them up. And we'll kind of discuss just briefly about C. diff infections and how the definition's used, and then how we can work on some prevention measures. So as I mentioned before, we're trending the right way for C. diff, which is really great. The baseline data was collected in 2015, infection and facility type. And regarding to C. diff infections, acute care hospitals are doing better. Our RIFs, our inpatient rehab facilities, and our long-term care hospitals are doing better as well, which is great. Nationally, we are doing better in these areas. And then compared to performing worse, we don't have any one facility in any category for C. diff infections performing worse than our baseline data that was in 2015. So that's really great that we are now seeing in the last 10 years, there's more initiatives with antibiotic stewardship and compliance and awareness around C. diff infections, but more work still needs to be done to help prevent this. So I'm just going to briefly talk about the NHSN C. diff infection so that we know what it is specifically, how they classify it, and what's the timelines. We'll look at the date of the event or event date, the location, how we determine what location, and then their specific criteria. So for event date, usually for CLABSIs and CODI, or the central line associated bloodstream infections, or a CODI, which is a catheter associated urinary tract infections, they use hospital day 2. And remember, for NHSN, that's hospital day. So that's not 24 hours admitted, it's the calendar day that you were admitted to the facility. So if you are admitted to a facility at 11:59 p.m. at night, that is considered day 1, and then the next day will start at 12:01. So just be very mindful with your specific date. They use calendar date, not hours of admissions of being in the facility for 24 hours. For C. diff infections, though, we look at greater hospital day of 3. So if it's day 3, 2, or 1, that's considered POA, present on admission. And if it's over day 3, then it's considered healthcare acquired infection, or HAI. And for this, our location of attribution, or LOA, is assigned on the date of the event of when that lab test is positive, or when we think of the transfer rule, the day before. So you always go back to the day before, the first location on the day before they were transferred for the specific location. And here is some direct algorithms that come out of NHSN, and this is from the 2025 manual that just came out this year. Specifically looking at your laboratory identified event, or your lab ID event, specifically for your algorithm in your facility. Depending on your facility's testing mechanism or algorithm, your steps might be different. So look at how you coded it in your National Healthcare Safety Annual Monthly Reporting Plan. That should be coming up, that's due soon. To set for the whole year of how you're looking at things. And then you can look at specifically if you're doing your facility-wide location, if you're doing select location, overall facility-wide inpatient, or your FAC-wide in, or your overall FAC-wide outpatient too. So this is different considerations when you're setting up your patient safety monthly reporting plan, and when you're choosing to report, and how, I mean, reporting is required, but depending on your testing capacity, it will kind of depend on some of these things. So look at your plans and follow this algorithm based on what you are deciding specifically for your facilities. And then we go into, when you're looking at your plan, what testing assay are you using? Are you doing a PCR? Are you doing the NAT, the GDH, or the EIA? And then this is kind of how you have the multi-step sample approach. This is cut right out of the manual as a reference, and which is always a good tool, especially if you're new to NHSN, the reporting manual, how they work up, looking at the different algorithms. This is always a great table to use to look to see if it counts or not, if it's eligible for a lab ID event. So you want to look at specifically your toxin with the 2-step algorithm. It can be GDH positive, but toxin negative, but they are specifically looking for that toxic producing organism. So if you're looking at it and it comes out as plus or plus minus, look at your specific assay that your lab is running, and then relate it to the testing method. And if you have questions about that, the best people to reach out to are your laboratory folks. to discuss what type of assay are you using, what's your positivity rate, what's your false positivity rate, your false negative rate as well, to kind of understand what's going on specifically in your facility, and then having that discussion about what platform you're using, so you are aware what platform you're using, so that then it matches your NHSN monthly reporting plan appropriately. And as I mentioned before, compared to central line associated bloodstream infections or catheter associated urinary tract infections, CLABSIs and CODIs, C. diff uses the third calendar day. So community onset, or CO, is deemed on hospital day 1, 2, and 3, but starting on hospital day 4, then it is a healthcare facility onset, or an HO, leading to a healthcare acquired infection, and HAI. So that is one difference with your lab IDs. That also does for your MRSA events as well too. They use the third calendar day, not the second. So make sure that you're working it up and that you're only counting the true positives on the 4th day of hospitalization. So that calendar day of the 4th day gets you into eligible for having a C. diff associated event related to a healthcare acquired infection. So now that we've talked about kind of what C. diff is, it is unlike some of the other healthcare acquired infections where there's this long algorithm. It's basically, is the patient in the hospital on 4 days or more, and do they have a positive lab result? That's it. That's all your definitions with C. diff. It is, do you have a laboratory result that is toxin producing positive, and have they been in your facility for 4 calendar days or more? That's in C. diff HAI. Compared to CLABSIs and CODIs and SSIs, there's more complex diagnosis, but C. diff's pretty straightforward. And so there's not a lot of wiggle room. If you're never quite sure, you can always email NHSN, just like with any other HAI, to ask for clarification or wanting more information. But usually with C. diff, it's an MRSA, any of your lab IDs, it's pretty cut and dry. There's no room for interpretation. Do you have a positive lab result that's toxin producing, and have they been in the hospital? So the next thing that now that we know about this, we know it's a spore. It's hard to live in our environment. There's risk factors for our patients. What are some good prevention measures that we can do to try to prevent C. diff from happening? And the first one is always hand hygiene. Hand hygiene is a fundamental way to prevent any healthcare acquired infections, create safe environments for our patients and staff by having clean hands. However, though, with C. diff, because it is a spore, alcohol-based products like your hand sanitizers are not effective on that. So you need to wash your hands with soap and water. Because it's a spore, alcohol does not penetrate into that spore, into the nucleus, to kill it. So that's why you need a bleach-based product or any other EPA-approved disinfectant. So this is really important that with all their products within your hospital, you are looking specifically at them under their chemical makeup. So you're reading that label of seeing what background is that. Is that an alcohol base, an ammonia base, an alkaline based, bleach base? Is it sporicidal, which you want? Sporicidal means that it kills spores. And then you want to make sure that you are then using this product appropriately for the manufacturers or IFU's directions for use. As we've talked about in previous modules, to always look at that specific instructions for use, IFUs, and then be cleaning appropriately. Usually with these sporicidal agents, they take a longer wet time because it needs longer time for the cleaner or disinfectant to penetrate that spores wall to get into the nucleus to kill it. So that's usually why it requires a longer period of time than some of your other products. So whatever products that you have in your hospital, go and check what it is effective on. It should say it's used for C. diff, C. auris, if it can be used for COVID, MRSA, ESBL, MDROs, it will list all of that. And then making sure you're following the instructions for use of how long it needs to stay wet. So we're washing our hands with soap and water because alcohol is not effective. We are not using alcohol-based products to clean the environment of these C. diff patients or people that are at risk for C. diff. And then we are putting them on contact isolation. So anytime we have a patient that has C. diff, we need to be cleaning specifically for that pathogen with certain products, and we need to make sure that we are isolating them, that they are, if available, in a single room by themselves, their own bathroom, and then healthcare staff and visitors are wearing the appropriate gown and gloves and having really good hand hygiene and donning and doffing procedures going into these rooms. The next thing that we can do, as I've mentioned before, is having good antibiotic stewardship. So making sure that we are identifying our patients that are at risk for C. diff infections and that we are and treating them appropriately, and that we are not just giving broad spectrum antibiotics to every single patient for any type of infection, and that we are only giving antibiotics for bacterial infections. We are not giving for viral infections or fungal infections. Those should be getting antivirals or antifungals. Next, we're doing patient education. So we are talking to our patient about their diagnosis, about this pathogen, how it's a very hardy spore. It can live in the environment for a long time. Patients can become colonized with C. diff and have these relapsing and recurring of infections. So that they're aware of that and that they're having really good hand hygiene and just overall good hygiene practice as well. Like anything to prevent the spread, if we have early detection, that is great, that we can monitor for symptoms such as diarrhea, abdominal pain, white count, looking at WBCs in our CBC panel is always a great way to potentially look at, do they have fever? Is there a high white count and like having diarrhea? It could possibly be C. diff. So that we are identifying that as soon as they're having the first symptom, and then we're testing appropriately. And then that we are then training and we have awareness about C. diff, what it looks like, symptomology, why it's important, why we need to be wearing our proper PPE, not using alcohol products because it's not effective, and that includes our alcohol-based hand sanitizers, and we are washing our hands with soap and water. Great ways to look at that, especially with monitoring, making sure that we are using our Bristol stool chart, which is here. Every facility, it might look different, but overall we have our classification of stool. It's our type 1 through type 7. C. diff should be tested and started looking at the differential when you have patients or residents that have stool in type 6 or 7. So it's that flaky, very liquidy, watery. That's when we should be testing our patients, but also be mindful that, say, if a patient is getting a colon prep, say they're getting a getting scoped, they're getting into surgery, they're having a colonoscopy, that, we're not testing them for C. diff because now they have watery diarrhea because they're getting colon prep. So making sure that there's mindfulness around what we are testing and who we are testing, and then making sure then we are putting them on isolation as soon as we are aware that we are donning and doffing appropriately, and we are cleaning with the effective and appropriate disinfectants. So that's all things that we can do on the staff side. The next thing that we are going to talk about is how we can get patients and family engaged in these prevention measures. As I kind of alluded to the first one, education and awareness. So not only should our staff be educated on this topic and be very much aware, but when we're talking to our patients, making sure that we are explaining the risk, why this is important, how they get C. diff, that it can relate to a serious infection, severe complications, and it can even lead to death. So making sure that we're having these clear communications with our patients, and that they're understanding that they know the why behind, that's most likely going to get them to be a good champion of hand hygiene and wearing PPE. Making sure that their visitors are wearing PPE and that their overall hand hygiene and overall hygiene is going well during their residency, or if they're in an acute care or long-term care facility as well, their stay. Making sure that when we are educating them, that we are, assessing their knowledge and that we're communicating this effectively to them. So making sure that you're using simple language. Showing visuals is great. Asking them what kind of learner they are, showing them the Bristol stools chart, especially if it's an independent patient and they are toileting themselves and they don't require any type of staff, making sure when they are admitted that they know to let their care team know if they are starting to have diarrhea immediately, and that it just doesn't go on for like a few days. And then, on the third day, they're telling the staff, hey, I've had diarrhea the last 3 days. Now it's starting to bother me, that they know what to look for and they're speaking up and communicating to their care team as soon as and also then if they are talking or wanting antibiotics, that you're educating them on the risk of antibiotics and why we shouldn't be giving them for everything, and that it's very specific, and that you're having that conversation around antibiotics if necessary. Always encouraging hand hygiene. This should be number one thing that we're talking to our patients, our residents, our healthcare. Everyone should be washing their hands, frequently washing their hands with soap and water, especially after they use the restroom. They're not using alcohol-based products, and then educate them on why they cannot use their alcohol-based hand hygiene product for C. diff. That is not effective. So if they're using it, tell them it's equivalent to not washing their hands. It's like they didn't wash their hands. So they need to be using soap and water. And then making sure that they are aware of their environment, asking them and kind of educating them to keep a tidy, clean space to try to reduce the spread of C. diff and the spores, so that the environmental cleaning is effective. The less materials that are in there, the less likely they're going to get exposed to some of these spores, and that these spores can get on clothing items, and after hospitalization, you don't want to accidentally contaminate their home with it. So having less personal items in the area is the best. Talking about antibiotic use and discussion. So involving them in the discussion of risk of unnecessary antibiotics, and then encourage them to ask questions about their antibiotics and kind of implore them to speak up and be part of their care team. And when you're rounding on your patients, to have this discussion and this awareness. Most of the time I have found that when patients and staff know the why behind something, why is it necessary, and what their risks and benefits are, and kind of breaking it down in that scenario, you're more likely to have a compliant staff member and also a compliant patient. So sharing guidelines, appropriate use, adherence. Everyone has a smartphone. You can tell them, direct them to the CDC page about C. diff. What can happen, why it's appropriate, hand hygiene, along with other sites as well too. And then always empowering our patients to speak up, always being great of teaching them what the symptoms look like. As I mentioned before, that they are promptly letting you know if they have diarrhea or abdominal pain or fever. If there's any changes and they're not feeling great, to let you know, and kind of, talk to them about this, especially if they're independent patients, that it's appropriate that they're telling you it's not a bother. It's, we're here, we're on the same team, and we want them to feel better. And if they don't start feeling well, we want to make sure that we know right away so that we can prevent any type of infection or bad outcome, and that we can get appropriate treatment for those things. And then also that, telling our patients to, hand hygiene is everyone's business, and reminding staff members and reminding their family members about isolation practices and donning and doffing, and kind of just, letting them know it's okay to ask and make sure and remind staff to do things if they're seeing that they're not being compliant. And then when you're getting ready, during their admission, anytime there's a C. diff diagnosis, if you can partner with their families and caregivers, share information of what's going on, how they can create a supportive system, train them on proper hand hygiene, infection prevention practices to reduce transmission. This is also very important. They might have some questions when they go home or when they are discharged from your facility, if these are patients in acute or long-term care, of what can we do to stay safe while we're in our own homes, that I live with my husband, or I live with my partner, I live with kids. What can I do to prevent them from getting the infection? And talk about cleaning, making sure that they're using a bleach-based cleaner at home, if they can be in their own bathroom, hand hygiene with soap and water is the best, and kind of talking about the home situation as well too. And then providing them with any visual aids, sending them to this CDC page, any other page. There's a lot of information out on C. diff. There's also a C. diff support group. There's a big C. diff advocate group too, as well. Providing them with that information as well can really get them on board with how to be compliant, and to help, get them feeling better and clear of the infection. And then lastly, a collaborative culture. So this should have two-way communication. It's a discussion, not just, you telling them everything, but also answering their questions, and that they feel comfortable asking questions, because if they don't feel comfortable asking questions, they probably do not understand, and they're not likely to be compliant. And definitely making this as a shared decision making when it can be, to really help improve adherence and understanding. So now we're going to kind of go through a case study of C. diff infections, some initiatives that you can do if these situations are happening in your hospital. These are steps that you can do. So just like our other modules, here is the QR code. You will have a quick learning activity that walks through a scenario of a C. diff. There's multiple choice. I encourage anyone to unmute themselves and to answer the question, have discussion about the scenario. You can also put your answers in the chat if you don't feel comfortable unmuting yourself. And then after the learning activity, then we'll open it up the floor for questions. So let's begin. So IP Heather is conducting a fourth quarter review of healthcare associated infections, or HAIs. So we're looking at all of our HAIs, our CLABSIs, our CODIs, our C. diffs, and our surgical site infections, our SSIs. And we are looking at our annual trend. We're comparing our previous year of 2023 to this past year of 2024. So I was looking back on our data, seeing where we are, where our opportunities for improvement are, and kind of knowing. So it's always really important in infection prevention to know your data, look at things, track it. You can kind of see if there are types of year that certain infections spring up, or different things that are going on. But as she's looking at the information, she is looking at 2023 versus 2024 based on our 4 HAIs, and then our quarters, our quarter 1, our quarter 2, quarter 3, quarter 4. So based on this information, which HAI has increased in 2024? Was it CLABSIs, CODIs, C. diff, or SSIs? Feel free to put it in the chat, or you can unmute yourself. What is the correct answer? Yes, it's C. diff. IP Heather notices a trend in our C. diff infections from 2023 to 2024. So now she's going to do a deeper dive into our analysis to look at specifically where are the infections. And the benefit of doing this is knowing your data. You can see if this is an isolated group, such as, C. diff infections are only arise in one area, or if this is a whole organizational wide issue. So now we're looking at the data at the very month level. So we're looking at our Q1 data, Q2, Q3, Q4, and we're looking at specifically what units in what months did we have C. diff infections. So we're seeing that there's 2 in January, 2 in February, 1 in March, and then April, it starts to tick up some more, kind of all over. We have 2A, 3CC, 4B, 2A, 3B, and then Q3, it goes up again. We're starting to see more infections. And then Q4, we're starting to see infections kind of all over in multiple different units. So by looking at our data, when we're starting to develop and identify that we have a C. diff infection problem, and we want to start developing a reduction plan, what units are we going to include in this project? Is this a unit-specific issue? Is only one unit having issues with C. diff, or is it kind of throughout the facility? What's the right answer? Yes, that's right. All the units, since from our data showed that this is not isolated in one unit, such as 4A is the only unit that's having C. diff infections, but you're seeing all throughout the year, there's different C. diff infection rates at every unit in your facility. So you're knowing that this is a systemic or an organizational issue. So after she looks at the data, she always wants to take the first step and talk to her department, her IP department or quality department to see what's kind of going on. Has the other IPs that she is working with know that there's an issue? Has there been meetings? Has there been concerns? Has there been other issues? Did we switch products? Huddling as a team is always great. Since we're all very, very busy, you might not know that this was discussed in another meeting that you weren't in, or that maybe that one of your other IP colleagues chairs a different committee than you. It's great to kind of have as a department come to a consensus, hey, this is a problem, and we are going to start developing a reduction plan, which involves the whole facility to start addressing some of these issues. So next, she looks at our data and she presents this data to her team to determine what key performance indicator or quality assurance performance improvement is really needed to help address this issue. So as we mentioned, when you're looking at your data and kind of what's going on, you want to make sure that you are including everybody in this issue. Because if you are going to do an organizational wide initiative, everyone needs to be on board. So having them in the beginning of the meetings is more beneficial than kind of catching them up along the way, especially when you are wanting to do different initiatives or different auditing. It's great. So because this is from our data we looked at, it's kind of happening all throughout the organization. What type of departments need to be in this meeting to kind of discuss what are we going to do about it? Should it only be nursing, only microbiology, all the departments that are in the process? So that's our EVS, our micro, nursing, our providers, MD clinicians. Is it our leadership? Who needs to be in this meeting? Or is it the whole departments of the organization, even our departments that don't provide care, such as our facilities or an engineer, our biosafety? Who needs to be in this meeting? What's the answer? Anyone brave enough to unmute themselves to share their thoughts? Great. The answer is B, all the departments that are in the process. So she is going to collaborate and set up this reduction plan, specifically to discuss and identify potential issues. Always going into this, you want to present the facts. You want to be very open. This is a very exploratory process. There shouldn't be blame at this stage of the reduction plan. You don't know exactly what's going on. So that's why you're meeting with all the leaders to see maybe something is going on in their department. And based on that, you're going to discuss at this big meeting specific things within their area. So for nursing, you're going to talk about C. diff prevention and auditing and the current process. How do they handle C. diff patients? Physicians, you'll look at the ordering and antibiotic stewardship. Microbiology, you'll look at their testing methodology, their positivity rate, what type of samples, is there an influx, did you change platforms? And that's why now you're seeing more positive rates. And then EVS or environmental services, you will look at their cleaning protocols specifically for C. diff. So having a very complete, robust picture will really help you drive your reduction rates on HAIs. And you can also get some of this information and kind of get an understanding of what's going on for your previous root cause analysis that you will conduct after you have healthcare acquired infections or HAIs. So in previous C. diff workups in their RCAs, you've learned from nursing that there's been a delay in collecting samples for C. diff patients. Physicians inappropriately are ordering tests. Microbiology sample collection and processing, there's been potential issues in the past. And then in EVS, making sure that they're using the appropriate clean, that they're communicated, they've been told that this is a C. diff room, there needs this product versus that product. So you want to make sure that you are looking at all this information. And just like any type, we want to, when we're doing goal setting, we always want to use the SMART acronym, be specific, measurable, obtainable, relevant, and timely. So when we consider that, we want to be specific and reasonable. So what type of KPI should we be looking at for these? That's a typo. It should be C. diff, not CLABSI reduction, but C. diff reduction. Is it reasonable to have 100% reduction? So we're going to 12 C. diff infections to 1 in quarter 1 or 0. Is it a 30 to 50% reduction? Is it 10% reduction or a 75% reduction from quarter 1? What do you think is a reasonable goal to put in a 3 months time? Yes, the correct answer is B. You always want to make sure that it's a reasonable goal that you're setting. And also when you're thinking about the goal, think about how much time it's going to gather information. If you need to develop a policy, a procedure, how long it's going to take a draft to get that through all your committees, educate all your staff on it when you're trying to set goals as well. So also be thinking about that too, to actually implement your reduction measures and then monitor it. That takes time. So making sure that when you're putting in your reduction efforts, that you are specifically calculating it and taking those into consideration. So next, when we talked about specifically with in the lecture, what is a way that we can educate our nursing staff on C. diff? Should we be reviewing the NHSN C. diff criteria with them, the Bristol stool chart with them, making sure our samples are appropriately, initiating contact precautions, maybe talking about donning and doffing? Or do D, all of those things need to be covered? What is the correct answer? Yes, great. D, all of them. We should be discussing all of those things with our nursing education. So we're going to push out education that includes the CDI criteria set by NHSM, looking at our Bristol stool chart so that they know what type of stools that we are looking for when we are initiating contact precautions, and then hand hygiene practices. The best things to do is always, if less is more, especially when we're doing education, that if you can put together a one-page handout of C. diff awareness, the importance, what they're looking for. That's easy compared to providing them like with a full packet of things. That's a better way of reaching your targeted audience. And they don't just see a huge packet and there's one more thing that they have to do and discard it. And then next, after you always do training and education, you want to do auditing to make sure that the training and education was done appropriately and effectively. So that means looking at contact precautions and then doing hand hygiene compliance. So you can audit this practice. There are plenty of tools. You can make your own spreadsheet to take on rounding on them, but you want to look at to see how your isolation and hand hygiene is being performed. So this is all information that when I look at patients, and these are all fake patients too, that you want to know who it is, their date of birth, since that age of 75 or 65, is a risk factor. So you want to make sure that you're knowing how old the patient is, what room that they are, where are they, what organism do they have, especially looking at isolation, donning and doffing and signage and appropriate PPE. So you want to make sure what organism that they have, if they have an indwelling device, which puts them at additional risk factors. So UC is urinary catheter, or CL is central line, shorthand. You can make up your own mnemonic. This is a pretty common one that's used. And then auditing, looking at, was isolation appropriate or not? Yes or no? Did they have the right isolation sign? Were they wearing the right PPE? And were they doing appropriate hand hygiene? So when we're looking at this, some of our C. diff patients, one had good signage, one didn't, and they're both using alcohol-based products, which is no go. This is another form. It's a CDC auditing form. I have a link here at the bottom for hand hygiene. Which is another way to look at it, different type of form. A spreadsheet is fine. ABHS is alcohol-based hand sanitizer. So that's that acronym. And then this is kind of seeing what type of staff, who is the issue, who is not being compliant with hand hygiene. Is it a certain type of staff? Is it just the clinicians or providers? Is it the nurses? Is it the aides? Who is having issues with this is a good way to document it. So based on that information that we just saw when we were auditing it, what areas need to be improved? Is it hand hygiene, isolation? Is it C, A, and B, since we had non-compliance with both of those items? Or is it D, no actions needed, and we're doing great, there's been no issues when you were auditing? What's the correct answer? Great, yep, it's C, A, and B. So we want to roll out education to increase contact precaution and hand hygiene compliance, making sure that they know to put these patients on isolation, what PPE to wear, and that they are washing their hands with soap and water. The next thing that we'll do is then meet with the physicians to talk about C. diff ordering, since we found that that was an issue in one of our previous meetings, and also talk about physician and pharmacy discussing drug administration and good antibiotic stewardship practices. So one of the things that she can do, or that you can do in your facility, is that if you're finding that there's an issues with ordering the test and isolation not being an initiative, not being done, is that you can build them in your EMR system and as a paired order set. So anytime that they are ordering a C. diff test, it can be paired with an isolation that prompts them to put them on contact isolation, which is great as a reminder. And then when you're looking at if there is an issue with ordering in your, you always want to have data, not just have hearsay of someone saying that there's a delay in ordering. You can ask your bioinformatics team or your EMR team or IT, depending on your facility and your capacity, to do a deep dive into your order set, specifically looking at date time orders, looking at symptoms, and kind of building your report based on the information that you want to see in that. So based on that, we build our report. We want to look at symptoms, the date that it was ordered. So symptoms, date ordered, time ordered, isolation ordered, and then if previous antibiotics were administered, and then any other additional comments that you want to have. So here that we're looking at symptom onset, and then we're looking at our order day, we're having onset of symptoms multiple days before we are actually ordering our test, which is problematic. And then we also have isolation not being started when we're doing ordering the test as well. So while we're reviewing the report, we see we are identifying these delays. There's a delay in sample collection. So we have documentation that the patients are having symptoms, but there's no ordering. So then you want to start talking with your physicians about, what is the delay in ordering, get them educated. You can also ask your EMR system to, have BPAs or alerts. But some organizations have 1 million alerts too. So you'd want to make sure that it's a meaningful alert if you're going to ask them to build the alert, and that the individuals aren't just having alert fatigue. And then also talk about, since we looked at our data and there was previous antibiotics given, that then having physicians or our clinicians and providers talk with our pharmacy to review and identify potential antibiotic administration to have better stewardship for these patients. So now we start, after our discussions and building, we see the following. So we have our symptom onset, we have our date of order, which you're looking at, it's pretty close match. It's the same day that the onset, they are ordering the test, and then that the isolation is being set to. And then also then documenting and following up that, are they having discussions with pharmacy about antibiotic stewardship? So after reviewing that, did we see an increase in compliance, a decrease, it remained the same, or we're not sure based on that information that we just saw after we built our report and pushed out education? Yes, that's right. We saw an increase in compliance. And then next we'll go talk with microbiology, discuss if there's been any changes of order frequency, positivity rate, indeterminate rate, and specimen rejection rate in our testing platform. It's always good to go have these conversations with lab to make sure that nothing's changed. And based on the information that you talk with them, you find out that there's no change. So there's really not an issue with any of the microbiology, but anytime that you're starting to see this trend or positivity rate increase, it's always good to ask, are these true positives? Are we worried? Did we change our platform? Anything shortages? Are you rejecting more specimens? Are there more indeterminates? Always good to talk to lab about what's going on. And then lastly, we're going to meet with our EVS to discuss cleaning practices. So we always want to do high touch surfaces. You can do a couple different ways to audit cleaning practices. You can use glow germ, which is black light testing, which is a special lotion that fluoresces under a black light to see if it's tested. You can do ATP testing, which is a little strip that has a meter and gives out a reading, or do environmental surface swab testing as well. Glow germ is usually the lowest cost, and then next is ATP testing, and then environmental swabs. Also be careful anytime you swab the environment, you are going to find something in one of those, regardless where you're at. And if you do find a positive culture, you're going to have to be actionable on that. So just always think and discuss it with leadership if you want to swab areas, or if it's really worth the investment and sending out for cultures and the cost, because it can get kind of expensive. So making sure that you're not swabbing 100 different places, or if it is, it's reasonable and actionable, and that it's justified that you're having this cost in your facility. And that kind of leads into this question. Based on the cleaning methodology, what should be considered? Cost, policy, or staffing? So anytime when you're thinking about an initiative, these are things that you should keep in your back of your mind. And yes, the answer is D, all the above. When you're looking at cost, is how expensive is this going to be? What does your policy say? Does it say that you're going to do one thing over another? And then do you have the manpower to do this as well? So due to low resource costs and time, you're going to use Glowderm. So you'll come up with a schedule, a monitoring tool, a spreadsheet is great. And you can look at your unit, your location, determine your high touch surfaces, which are always my go-to are my door handle, call light, bed rails, over tables, IV poles, patient sinks. So that the first one is patient areas. And then the second one is non-patient areas, which are our unit keyboards, our unit phones, our workstation on wheels or our WOWs, shared equipment, sinks, and waiting area. So then you can come up with a pass fail if it, you put the lotion on and then they come and clean it. And if it still glows when you put the black light on it, it doesn't show effective cleaning as a pass fail. And then you can kind of see what's going on. So when you do different areas in different rooms, you're not really seeing a trend. Some are passing, some are failing. So based on that information, is there an issue with your cleaning practice in your facility? A, no. B, yes. C, unsure. Yes, that's right. B is yes, there is a problem. Since we're not seeing all passes, which we should. So you want to discuss non-compliance, create an action plan with key stakeholders. So it's a collaborative. Who is responsible for cleaning the unit? Is it EVS or is it nursing? Some of these are shared responsibilities. Do re-educating cleaning practices, and then audit the schedule and determine together what the type of frequency and duration should be. So kind of breaking it down to EVS will monitor and do so many audits, and IP will do so many audits as well, and then discuss the findings. So then after we do all this, we'll set up IP. Heather decides to set up monthly meetings to discuss new initiatives. We'll confirm education has been rolled out, physician compliance, microbiology, and then our environmental services, and kind of discuss what is going on with the initiatives and how we are trending. So then in March, then we see the following. After we have rolled all this out in January, February, and March, we start seeing our C. diff numbers drop, which is great. So a total of 6 for the quarter. And our last question is, what percentage of reduction going from Q4 to Q1? Did we have a 50%, 40%, 30%, 20%? So we went from 12 C. diffs in Q4 of the last year to 6 in Q1. So yes, the right answer is A, 50%. And then here are the answers for anyone to review. And then just lastly, C. diff is a very, very persistent, complex, challenging problem that we have in our healthcare. It involves very much compliance with every department of having good IPC policies, procedures implemented, and definitely working with our patients to kind of tell them the importance and engaging them to help kind of be very compliant with these. So you should always look at your contact precautions when it comes to C. diff, timely testing, infectious period windows, cleaning protocols, and make sure that these are always collaborative efforts. And then also having a robust antibiotic stewardship program can really help eliminate C. diff infections in your facility. So here's just some information if you want to connect with us. Here is our email specifically. If you have questions, concerns, email at IPC. Here is the QR code if you want to learn more about TEFI. Our next module will be on IPC training for infection preventionists and other ancillary staff in your facility. So nurses, our providers, and our other healthcare workers. We ask that everyone completes a post-module evaluation on today's topic. And if you complete it, you will be entered into win some TEFI swag that will be mailed out for you. It's really great when you guys complete this. It lets us know how we're doing, ways to improve, what other additional topics that you would like to see and present to really help serve you and making sure that we are bringing the information that you are needing and wanting at this time. And then I forgot to mention this lecture is approved for an hour of continuing education. If you have your AIPC or your CIC certification, 1 hour of continuing education, or if you have your CPH as well. Here are the steps. Again, this lecture is recorded. You will receive a link to the recording in a week or so, along with the slide decks. You'll have all this information, and you can go claim your continuing education credits there. And now I just want to say thank you for all attending, and I will open it up for any questions. Any questions from anyone?
Do you have any suggestions in an area that isn't a clinical setting, but something that is more an office environment, something that can be done if we have something, a person that gets ill in an office environment? Regarding cleaning products, something that's not a hospital only.
Yeah, so any bleach-based product is effective. So it doesn't need to be, if you're in an office setting and you have one of your coworkers get C. diff. Best thing to do is to they should be continent. If they're having diarrhea, of course, we shouldn't be coming to work. But in those cleaning areas, any bleach-based product is really effective. You can go to Walmart, Target, Amazon, anything really that has bleach in it. Just be careful though with bleach. Some equipment it can't be used on. It can cause it to degrade. So if you have any like computers or keyboards, anything like that, ask your IT folks if you have any of those devices of what can be used to clean them so you don't ruin that. But desks, chairs, those types of common areas, any bleach-based product, and then making sure that you're just reading the directions that it says stay wet means that that surface needs to stay wet, or it'll say contact time or wet time. It's staying wet for the period. It usually will say 2 to 4 minutes. There's some products that requires 2 minutes, some 3, some 4, some 5. So just making sure that you're reading that instruction. But overall, that should really do it. Any, reusable thing is getting cleaned. Any going through the dishwasher with, if you have any dishes, that can kill the spores as well too.
Thank you.
You're welcome.
I have a question.
Yeah.
So NHSN is putting out this antibiotic use data. It gives you your SAR rates.
Yep.
That's it, right?
Yep.
So, we've looked at that data and we have like a medical unit that seems to be higher than everyone else. And so I'm trying to pin down the antibiotic use, and what it's for. But my concern is are people using that data now, or does there still need to be work done from the NHSN side on that data? Do you know?
That's a great question. I do not know. I know they are putting out those reports and it is publicly available. Like when you go onto the CDC site, you can pull up your HAIs and antibiotic usage. However, with your well, I say that now, and then with other things, they're kind of hard to find. That data is publicly available. But at your facility, I would definitely loop in pharmacy and really discuss your antibiogram, especially if you have clinicians from other facilities. Sometimes when they come over, there's a particular, if they're at one hospital, they have privilege and they're coming over to another hospital. Those patients that they are serving, might be very different. Different, health statuses, environmental risks, social economic things, and that puts them in different risk categories. So they might be prescribing the same antibiotics for two different patient sets. So definitely making sure that you're talking with pharmacy. They're really championing your antibiotic stewardship levels and appropriateness, and that they feel comfortable discussing with providers. Because I know some providers, it is very much a culture of how well they get along with pharmacy, of calling them, they feel comfortable changing orders, having discussion with it, that they are reviewing their orders. So kind of, maybe facilitating that conversation to see what's going on, or there might be a shortage of a specific antibiotic in your area. So they went to prescribing something else. Maybe it hasn't been discussed. Those are other types of approaches that you can kind of dive into to see what's kind of going on, specifically in a unit. Is it a certain medical workup that they're prescribing for, or is it just a unit culture of always prescribing this? Is it just a physician's preference to always give out this antibiotic? Are they using broad spectrum, or they're using narrow?
They're using ceftriaxone quite a bit, and it seems to be in order to meet sepsis protocols. When these patients come in sepsis, they think it's sepsis. They may meet the protocol, and then they'll say, "Oh, it looks like a UTI," and
right.
But then when we get the cultures back, it's really not. And so it's stuff like that going on. And I know pharmacy knows about it, but it's like trying to change that culture. It's kind of like they don't know how to prescribe differently.
Right. And I would definitely maybe loop in, if you have a sepsis coordinator, to have, this discussion too, because I know with sepsis alert and in the quality, there is a very metric driven way that, your sepsis protocol has to be met, within 4 hours, and, a lactate needs to be drawn, antibiotics to be given. Maybe having, yes, that it could be sepsis, but also that, we're not driving antibiotic usage up, and then on the back end we're having now C. diff infections. So kind of having a multidisciplinary team discussion about that too, because I have seen that sometimes when there's a heavy pressure to meet that sepsis requirement in that time frame.
In ED, and then it continues on once they get in the unit.
Yeah, and then you have people just starting antibiotics and not falling off. They're on it, and then when you're rounding on it, it's, oh, they've been on this for 5 days. What are they for? And no one has stopped it too. So definitely having I would maybe suggest having a meeting with sepsis, pharmacy, and the medical director or unit director of that area. And then also if it's, a physician champion too for antibiotic stewardship, to make sure that everybody's on the same page about this. Because
I think what they want is they want to know, because they do have pharmacists that are on the unit, that kind of thing, and they're trying to help them, but it's like the data is so scrambled and wide and large. It's like digging down to those specific cases, what I mean, that are getting these antibiotics. They don't all get C. diff, but that risk is there.
Right.
I mean,
yeah.
So we're working on it.
Yeah, if you have more specific questions, I'm happy to take this offline. You can email me at the IPC, and if you we can talk more specific if you need some help. I'm happy to talk
Is
more.
your email address on there? Maybe.
Yeah. It is on the slide that says connect with us, the IPC email, you can email.
Okay.
Right here.
Oh, great. Let me just snip that.
And then you'll have a copy of these slide decks in about a week when you get the email with the recording for today's lecture too.
Great. Thank you.
You're welcome. Any other questions? or if anyone has any specific questions or a scenario that's going on at their facility, I'm happy to walk through that with you and talk more. You can email the IPC and we can set up a time to talk or discuss. I'm happy to help wherever I can. Any other questions? No? Okay, well, thank you all for attending today's lecture. Next month's lecture is April 3rd. Here's a QR code for registration. We're gonna be talking just a brief overview about IPC training, so how you should be training your infection preventionists, and then what kind of education or what top infection prevention and control education should you be providing to your nurses, your providers, and ancillary work. Well, thank you all for attending, and I hope you have a wonderful rest of the week. And we'll see you next time. Thank you.